All right, well, thank you everybody for joining us today. It's about 3 after the hour, and we're going to get going. Thank you to the near 100 people that have joined us thus far, and I'm sure we'll have a few more trickling in as we continue to go. As I said before, we kindly ask that if you're not speaking to please mute your microphone. We would not want to interrupt or be an inconvenience of any type to any of our speakers. And with that, I'd now like to turn the call over to Rich Hamburg from Trust for America's Health. Thank you, Rich.
Thanks a lot. Good morning, or good afternoon, all. On behalf of the Collaborative for Effective Prescription Opioid Policies, known as CEPOP, welcome to the first installment of the CEPOP Salutes program. We have a packed agenda for today's webinar, including opening remarks from Dr. Kate Goodrich, Director of the Center for Clinical Standards and Quality at the Centers for Medicare and Medicaid Services, and presentations from 3 leaders in the fight against the opioid epidemic. We'll be muting all lines on the webinar to ensure our speakers have the opportunity to present without interruption. If you have a question, you may submit it to us in the chat box on the bottom right of your screen or virtually raise your hand. Today's webinar will be focused on the role that hospitals and hospital engagement networks specifically have in efforts to lead in the reduction of opioid overutilization and injury. As most of you know, opioid abuse is affecting our country from coast to coast, which can be evidenced by the broad turnout for today's webinar. During the next 90 minutes, we'll provide participants with a better understanding of the role that hospitals have in addressing the opioid epidemic, especially given the importance of appropriate acute pain management in the hospital setting, including following surgery. We're fortunate to have representatives from the Michigan Health and Hospital Association Keystone Center, the Hospital and Healthcare Association of Pennsylvania, as well as Dr. Anita Gupta, prominent clinician in the pain management arena, to provide a brief overview of their work and help stem the problem. As a co-founder of CEPOP, Trust for America's Health cannot be more pleased to have such a strong turnout for today's call. CEPOP includes 70 organizations that span the full range of stakeholders. Founded in January 2015, CEPOP promotes a comprehensive and balanced strategy to reduce prescription drug abuse and promote safe treatment options. For more information on CEPOP, please visit www.cepoponline.org. We'd like to take a moment to set the stage for this afternoon's discussion, highlighting some key facts surrounding the opioid epidemic and the immense toll that it has taken on families and communities nationwide. These slides serve to depict the responses put forth by government agencies, legislators, and the private sector to begin to make an impact. Next slide. So since 1999, U.S. sales of prescription opioids have quadrupled. It's a 6.5% increase just from 2013. And over 60% of drug overdose deaths were due to an opioid, heroin included in that figure. And while prescriptions for opioid medications now remain steady, deaths due to opioid overdose continue to climb, and you'll see some other statistics up there. As far as the government response is concerned, we've had a number of actions taken recently. You'll see them all up there on your screen. We'll highlight just a few. The CDC's guidelines several months ago for prescribing opioids for chronic pain was a major addition to the discussion around the response. The Comprehensive Addiction and Recovery Act of 2016 that contained literally dozens of provisions and individual bills in a comprehensive effort to address the opioid epidemic. Tied to that is or are efforts to not only increase federal funding. We've seen quite a bit of increased funding, but also to ensure that those amounts that were authorized in the Comprehensive Addiction Recovery Act, known as CARA, that we see those dollars as well. One other thing to highlight are the medication-assisted treatment caps. There have been a long discussion around that. The MAT federal regulation will now allow physicians who have prescribed buprenorphine to 100 patients for at least 1 year can now apply to increase their patient limit to 275. This was published by SAMHSA in July 2016, finalized just last Monday. for the recalibration and reimbursement of HCA-HPS pain scores, CMS has suggested to remove pain scores from the hospital value-based purchasing calculation. That's been a big issue as well. And then on the next slide, you'll see a number of changes in patient prescribing. Won't go into those, but just say that a number of protocols from some leading organizations have been updated relatively recently. I'd like to now turn the webinar over to my friend and colleague, Congresswoman Mary Bono, to welcome our first speaker. Mary?
Thanks, Rich. Good afternoon, everybody. My name, as Rich just said, is Mary Bono, and I'm a former Congresswoman from California. I'm another co-founder of CEPOP as well. So during my service in Congress and well beyond, I've dedicated my career to shining a light on the opioid abuse, misuse, and diversion crisis. While in the House, I started the Congressional Caucus on Prescription Drug Abuse with my good friend, Congressman Hal Rogers of Kentucky. That's a state, as we all know, that has been ravaged by this epidemic. So CEPOP is a force to drive awareness around this serious public health challenge. Recently, government agencies such as CMS, CDC, FDA, and many others, alongside our legislators, have begun to focus on solutions to the opioid epidemic. The recent enactment of the Comprehensive Addiction and Recovery Act, or as Rich said, CARA, it's a step in the right direction, but so much more work is needed, and that's why we're all gathered here today, to recognize the efforts that are already underway in America's hospitals to help patients and families. So to that end, it is my pleasure to introduce Dr. Kate Goodrich, Director of the Center for Clinical Standards and Quality at the Centers for Medicare and Medicaid Services. Dr. Goodrich received her medical degree from Louisiana State University, and she completed her residency at George Washington University Medical Center. In her role as Director of CCSQ, Dr. Goodrich oversees more than 20 quality measurement and value-based purchasing programs. So we're happy to welcome you today, Dr. Goodrich, and thank you very much for joining our CEPOP Salutes. Over to you.
So what I had wanted to do at the beginning, but I'll do now, is to really give you all sort of an overview of the Partnership for Patients program and our work with the hospital engagement networks. And then I'm going to just talk a little bit about some of the other work we're doing at CMS around opioid policies. I co-lead a working group with Shantanu Agarwal, Dr. Shantanu Agarwal, who is the director of our Center for Program Integrity on opioid policies across CMS. But let me start with Partnership for Patients. So the partnership began in 2011. It is a high priority initiative for CMS and for the administration, and it actively supports 3,700 of the nation's 5,000 hospitals, designed to reduce 30-day hospital readmissions by 20%, and to reduce all-cause preventable inpatient harm, which includes opioid-related adverse drug events, by 40%. And a primary vehicle for achieving these aims are the Hospital Engagement Network hospitals, and you've just heard from two of our HINs. These state, regional, national, and hospital system organizations currently support the approximately 3,700 hospitals. And through this expansive learning community, best practices are shared in support of rapid cycle innovation to address contributing factors to harms and readmissions. And critical to the success of the HENS and the entire Partnership for Patients program are the partnerships that are formed. Partnerships across the care continuum contribute to this very large quality improvement effort. These include partnerships that we have with federal agencies such as the Centers for Disease Control, the Agency for Healthcare Research and Quality, or AHRQ, as well as public and private associations and organizations. But partnership also includes community collaboration as well as engagement of patients and families in order to address urgent matters of public health, such as the opioid crisis. The hospital engagement networks focus their work on 10 key forms of preventable harm where proven practices exist for helping hospitals and caregivers to achieve rapid progress. Adverse drug events were the single largest category of harm and represented a major focus of the work of the HENS. The networks have aligned with the National Action Plan for Adverse Drug Event Reduction and have addressed the 3 most frequent classes of drug-related harms in the acute care settings, with opioid harm prevention as one major focus. Now, the Agency for Healthcare Research and Quality National Scorecard for Hospital-Acquired Harms identifies these adverse drug events as the largest area of hospital-acquired harm, nearly 1/3 of all harms of focus. The data collected through the scorecard showed that there was an estimated $4.19 billion in cost savings and 16,760 lives saved as a result of the reductions in adverse drug events through the end of 2014 compared to the 2010 baseline. And since the baseline of 2010 through the year 2014 for Partnership for Patients, there's been a national decrease in hospital-acquired harms of 17%, and 40% of that reduction was due to adverse drug event reductions at the hospital level. And through collaboratives such as these, there's been a 39% reduction in preventable harm, resulting in 2.1 million fewer patients harmed, 87,000 lives saved, and nearly $20 billion in cost savings. These results have just been extraordinary. So at CMS, we are extremely proud of the work that's been done by our partner organizations and the HINs, such as the ones that have already been featured in this webinar, to reduce adverse events due to medications. So I also want to briefly highlight some of the other efforts that are underway at CMS and HHS to address the opioid epidemic. And this is just a small sampling of what is really a quite large inventory of activities that's underway, with many more being planned. I first want to say that addressing the opioid epidemic and safe prescribing practices is of paramount importance to Secretary Burwell and to us at CMS. And the Secretary has identified 3 broad areas of focus. Number 1, opioid prescribing practices in order to reduce opioid use disorders and overdose. Number 2, expansion of the use and distribution of naloxone. And number 3, expansion of medication-assisted treatments to reduce opioid disorders and overdose. So if you highlight a few initiatives just to highlight at CMS, number 1 is something you all may be familiar with, which is our opioid drug mapping tool, which is an online interactive mapping tool that allows for geographic comparisons of opioid prescriptions for Medicare beneficiaries by state, county, and zip code. Number 2 is a companion large quality improvement effort called the Transforming Clinical Practice Initiative, which is a national effort to help clinicians transform their clinical practices towards value-based and alternative payment models. And many of these practices are choosing to focus on safe prescribing practices around opioids as an area for improvement, including the use of measures of safe opioid prescribing. And as was mentioned earlier, we recently proposed in one of our regulations to de-link the performance on pain questions on the patient experience of care surveys from hospital payment, really out of an abundance of caution. We had heard from clinicians that they were sometimes feeling pressured by hospitals to prescribe more opioids in order to achieve higher scores on these surveys. However, we do believe that pain control is a critically important issue for hospitalized patients. So we are testing new survey questions that focus more on the communication between patients and clinicians about expectations for pain management, as well as adverse events related to pain medications and other alternative therapies for pain control. And finally, we are looking at ways in which we can incentivize clinician education activities and better patient outcomes through the new merit-based incentive payment system, which is a new payment system for clinicians that bases payment on quality of care provided, cost of care, and use of technology and practice improvement activities. So addressing the opioid epidemic using the various levers that CMS has available is an extremely high priority for the agency. I want to thank you all for allowing me to say a few words in the middle of the webinar. It's been great to hear about the marvelous work that's happened with our HENs, and I look forward to the next presentation. And I'm going to turn it back over to Rich. Thank you.
Thanks, Dr. Goodrich. Appreciate it. So, as we mentioned, today's webinar is the first in a series of events to highlight individuals and organizations for their efforts in this area. Each of our speakers today has been nominated for the CEPOP Salutes Award for their leadership in improving the way the nation manages and treats pain. Please note that while the focus of today's discussion is on the inpatient setting, CEPOP Salutes program covers the entire spectrum of patient care, from the inpatient setting through outpatient care and, where necessary, treatment and recovery programs. Kindly ask that any questions that you hold any questions until all three of our presenters have had an opportunity to speak. We have 15 minutes allocated for Q&A at the end of their presentations. Our first presenter today is Michelle Norcross. Michelle is the Director of Performance Improvement at the Michigan Health and Hospital Association Keystone Center. Keystone Center is a certified patient safety organization through the Agency for Healthcare Research and Quality, founded in 2003. The organization is one of 17 contracted as a hospital engagement network through CMS, and now includes both the MHA and Illinois Hospital Association in an effort to guide participating members through a variety of best practices and resources to reduce hospital-acquired conditions by 40% and preventable readmissions by 20% over the course of a year. Welcome, Michelle. Turn it over to you.
Thank you so much, Rich, for the kind introduction. I think that we all know that there's an opioid crisis happening right now, but I wanted to share a few facts that I personally found startling when focusing on this work. The first is that, you know, the United States residents constitute less than 5% of the world's population, and yet they consume 80% of the global opioid supply and 99% of the global hydrocodone supply. The number of opioid deaths has tripled since 1999, and as of 2012, Michigan ranked 10th amongst the states in capita prescribing rates of opioid pain relievers and 18th in the nation based upon numbers of opioid overdose deaths. Michigan hospitals established the MHA Keystone Center in 2003 to create a sustainable change addressing the Institute of Medicine aims: safety, efficiency, effectiveness, equity, patient-centeredness, and timeliness of care, while improving the culture of safety. In 2013, following a number of highly successful and federally funded initiatives, the MHA Keystone Center chose to target adverse drug events related to opioids in the perioperative setting. An advisory committee of anesthesiologists, surgeons, and nurses was formed, and a gap analysis tool was developed and adapted. We also held a launch meeting with initial educational materials that were distributed to each surgical hospital participating in the collaborative. Gap analysis tools were analyzed every 6 months, outcome measured every 3, and educational webinars and live meetings were held throughout the state. Patient education products were developed to aid with expectation management. Utilization of tools steadily increased over the project, and satisfaction of enrolled hospitals was high. Although difficulty was encountered in collecting specific measures, trends towards improvement in safety and adverse events were observed at a number of participating centers. The project has since been expanded to include non-surgical inpatients and emergency department patients, and as Rich mentioned, it's also been launched in another state, Illinois. We started out with the Opioid Adverse Event Prevention Gap Analysis, and with permission from the Minnesota Hospital Association, we adapted their gap analysis tool, which consisted of a series of evidence-based and best pain practices. The gap analysis consisted of 57 questions and included a wide variety of topics, including prevention and mitigation strategies, assessment and detection strategies, therapeutic strategies, critical thinking and knowledge strategies, and these were all incorporated into an online tool that hospitals took twice a year. The findings were reviewed with the advisory committee, and we created an implementation plan for a year-long project to disseminate best practices, offer resources, and discuss areas of opportunity. The results of the gap analysis were analyzed every 6 months, and outcomes were measured every 3. Based on the information obtained through the gap analysis, educational webinars and live meetings were held throughout the state, targeting identified opportunities for improvement. We had 3 main interventions that we utilized to improve pain control and reduce opioid-related adverse events. The first was the Comprehensive Unit-Based Safety Project, also known as CUSP, which follows a 6-step iterative process to improve patient safety and culture that drives safety and attitude practices. If you're not familiar with CUSP, or if you'd like more information on CUSP, you can certainly visit the Agency for Healthcare Research and Quality, AHRQ website, for more information. The second intervention was educational programs, including both in-person and multimedia sessions. We offered monthly content webinars, monthly coaching calls within the collaboration for the Armstrong Institute for Patient Safety and Quality and Johns Hopkins University, and an annual conference which was in person with national speakers. We also had an implementation of a perioperative pain management toolkit, which include the gap analysis, which I talked about, the Michigan Opioid Safety Score MOS tool, patient and family educational templates, which I will be going over shortly, and then the preoperative check-click modification, thus discussing pain management and concerns related to pain in your surgical briefing and debriefing, and a multimodal analgesia tool with specific recommendations for order sets. The Michigan Opioid Safety Score was developed by Dr. Roy Soto, who's the current physician champion for the MHA Keystone Pain Management Collaborative. The goal of the tool was to incorporate patient and procedural risk factors, incorporate respiratory rate, sedation, reinforce the need for multimodal analgesia, and improve the nursing documentation of patient assessment. This tool actually also had some unintended benefits, including nursing empowerment. Several nurses pointed out the benefit of the tool as it provided them with documentation that they could use when a doctor or a patient tried to push them to give them more narcotics, even if they knew it wasn't safe for the patient. And this was actually published in June of 2015 in the Journal of Peri-Anesthesia Nursing. So how does this tool work? The MOS is a health risk score with a maximum of 2 points, plus the respiratory rate score, plus or minus the modified Passero opioid-induced sedation scale, MPOS, or STOP modifier. As you can see in this portion A, you can score 1 point per group under health risk, but again, a maximum score of 2. Then respiratory rate is scored based on the respiratory rate greater than or equal to 10 or less than 10. And the STOP modifier is if the patient's excessively sedated, drifts off to sleep, difficult to arouse, or unarousable. Then you come up with a total score. Again, the STOP modifier is going to tell you to stop all opioids and provides you with recommendations to notify primary physician, increase monitoring, consider a pain consult, ensure the use of multimodal analgesia, and consider reversal agents. A score of 3 to 4 tells you to use caution, and again provides recommendations to decrease opioid dose, increase levels of monitoring, ensure multimodal analgesia is delivered. Then a score of 2 shows concern, which notes the patient's at risk. Then you'll be able to increase opioids as needed with special attention that you should consider increasing levels of monitoring, and again ensure multimodal analgesia is delivered. Finally, a score of 0 to 1 means you're safe to proceed with further opioid dosing, but still should ensure multimodal analgesia is delivered. We recommend patients be scored on a MOS prior to administration of opioids. As a reminder, this can also help with conversations with patients because they understand that they're at risk if they receive additional opioids, but yet you can still share with them that you'll be able to provide them pain control, though it may not be opioids, especially as the first line of defense. As I just noted, we feel that patient engagement is vital in care. In fact, it's one of our foundational elements. And this is a brochure for our surgery collaborative intended to educate patients on pain after surgery and assist them with expectation management. 35% of Americans function at or below a basic level of literacy, which is important for us to develop a tool between the 6th and 8th grade reading level. We worked with a team of experts, including an anesthesiologist, a surgeon, a health literacy expert, and our Patient and Family Engagement Advisory Council to ensure that we were getting information to the patients that they actually need. Our goal was to help set expectations that patient will have pain after surgery, and we broke down the tool into what you should do and then why it's important to do these items. We provide them with tools to help track their pain and side effects and share with them that expectation is to keep their pain at or below a realistic level of 4 out of 10 following surgery. We also provide them with an opportunity to document their pain management plan, as well as a location to track the pain medication that they are taking. Finally, we included a list of common medications, ingredients, and side effects so patients had a better understanding of the medications and what side effects they should look out for. Utilization of these tools steadily increased over the 1-year project, and satisfaction amongst those hospitals providing these to patients was high. Approximately 50,000 of these tools have been ordered and shipped across the state, and resources have been endorsed by the Empowered Patient Coalition and Engaged Patients, both nationally recognized patient engagement organizations. So what were the results? We had 38 hospitals participating in MHA Keystone surgery, and again, although difficulty was encountered in collecting specific measures, 24 hospitals submitted the gap analysis, and 29 hospitals submitted data on a monthly basis, which is noted in this slide. Trends towards decreasing in the rate in adverse events was seen at a number of participating centers, and an increase in utilization of the MOS tool was also seen. The project has since expanded to include not only surgical patients, but non-surgical inpatient and emergency department patients with the launch of the Michigan Health and Hospital Association Keystone Center Pain Management Collaborative. We also pushed this out to Illinois, which is the additional state that we participate with in the Hospital Engagement Network 2.0. The goal of the collaborative is to reduce opioid-related adverse events, improve appropriate pain management, decrease the usage of opioids statewide, and enhance patient expectation management. 75 hospitals are actively participating and have agreed to the following asks, which were listed on the slide, and we're also informed by evidence-based best practice and gap analysis results. We continue to provide an educational resource and offerings, a toolkit of evidence-based best practices, and we've also developed additional patient-facing materials, including 10 things every patient in pain should know. One recommendation put forth by the Governor Snyder's task force related to opioids was to develop a public awareness campaign, inform public on dangers of abuse, and safeguard and properly dispose of medications, publicize improper prescription practices, and reduce stigma. So we launched this tool nationally with the Empowered Patient Coalition and Engaged Patients, and we were able to make 1.5 million impressions during a Twitter chat around this tool. We also did a 10-day social media campaign launching this tool. Further, we're currently working with the Michigan Pharmacists Association and the Michigan Department of Environmental Quality to develop a tool to educate people on why they should dispose of their medication and how to do so appropriately. And we're also working on building an interactive map similar to Google Maps, which will house a comprehensive list of all take-back locations in Michigan, which currently does not exist. As we all know, there's still much to be done, and I certainly hope that there's something today that you'll be able to take away from the work that's being done in Michigan and now in Illinois. So we will certainly take questions at the end of today's call, but I'd certainly like to thank you for your time and attention.
So with that said, what I'd like to do is to turn the call over to Matthew Grissinger from Pennsylvania. Matthew, why don't you take it away?
Great. Thank you very much, guys, and thanks, Michelle, for the lead-in. And it's great to see the work that Michigan's been doing on their HEM project as well. So yeah, my name is Matt Grissinger. Let me go to the next slide here, just describe the relationships in Pennsylvania. So as a part of the HEM projects in Pennsylvania, there are many organizations involved overall. So the Hospital Association of Health Systems in Pennsylvania is the HEM leader with the Pennsylvania Patient Safety Authority, which is the authority in Pennsylvania that manages the error reporting program in Pennsylvania. And the Institute for Safe Medication Practices, where I work, works with the PSA and HAP in this HEM collaborative. So it's important to note that there are many people working on this project, and it's probably due to the success that we had. So a couple things we're going to go over the next 15 minutes is talk about the tools that we use to identify issues up front. So one of the main goals that we had was to have organizations take a look in the mirror and identify risk within their own organizations, similar to you saw the gap analysis that Michigan did. So it's the same idea. We just call them assessments. There are links within this slide. So you get the slide, you better click on those links to actually get to the tool that's located on the Pennsylvania Patient Safety Authority's website. So what I'm going to go over today is the knowledge assessment we did and why, and the organization assessment, and then touch on the measures as well. So the first thing we did when we entered the project was we developed a opioid knowledge assessment. So this was basically a way to assess healthcare practitioners' basic knowledge about opioids. And it was a simple 11-question multiple choice test. The key thing was it was intended for all prescribers who would touch an opioid in any way, shape, or form. So yes, that includes prescribers as well as pharmacists and nurses. And the other beneficial thing about this knowledge assessment and the process we had was we were lucky enough to work collaboratively with the Pennsylvania Medical Society, who reviewed this test, made suggested changes, and endorsed this knowledge self-assessment, which is important, and I'll tell you why in 2 slides. So to give you an idea of what the knowledge assessment was asking, it was asking types of questions in regards to how would you know if a patient was opioid naive versus opioid tolerant? And that's a big deal because that alone will help determine what is an appropriate opioid if you're going to prescribe an opioid, and what would not be inappropriate to prescribe, whether it's a dose or a type of formulation as an example. We asked a question about long-acting opioids, and we'll talk about that also in the organization assessment. Questions about equity analgesic dosing. So, for example, if you're going to give someone so much morphine, what's the equivalent in hydromorphone? That was a question we asked because for years, many practitioners have no idea that it's not a one-to-one ratio of morphine to hydromorphone. In fact, it's up to 7-to-1 depending on what reference you use. Also, patient-specific conditions requiring lowering a starting dose of an opioid, similar to what Michigan identified earlier. What use of concomitant medications and which ones may increase the level of sedation with an opioid, and also how to monitor the effects of an opioid. So what you see in this slide is just showing the number of responses overall to that assessment. So you see the first go-around of this assessment, we had over 2,200 people log into the site, and only 1,700 completed the test. Why only 1,700 completed the test, I don't know. But what is nice, and I think this comes back to our work with the Pennsylvania Medical Society, the fact by the sheer number of physicians that participated in this assessment. If you took, for example, the number of prescribers here, physicians here, residents here, and PA nurse practitioners, physician assistants, nurse practitioners who can also prescribe at times, that adds up to close to 30% of the respondents were prescribers. And that is a pretty impressive, to me, very impressive return for a prescriber. Half were nurses, followed by pharmacists at 15% here. So let's give you an example question. Luckily, there's not polling questions here. We can ask people this question to see how you would score. But this is the first question we asked. So this was getting at the point of, are the people that we're testing aware of what makes someone opioid tolerant? So the question is, patients who are considered opioid tolerant are those who have been on which of those 4 orders, letters A through D, or all the above? To cut to the chase, the correct answer is only the letter C, and that's because of the fact that you're getting a certain amount of oxycodone 4 times a day for 14 days is the key thing. Someone who's opioid tolerant is taking continuously morphine or oxycodone or fentanyl or hydromorphone continuously 24 hours a day for 7 days, and there's milligram recommendations within that too I won't go into. So let's look at the results of how people scored in that test, or that question. So this is how many people selected each answer. And so some concerns here, well, number one, the correct answer is here. So less than 30% of the people got that correct. And in fact, way more than half chose all the above, which means, you know, to me, their thinking is, well, if they're on morphine for a day, they're tolerant, and which is not at all true. Again, it's up to a week's worth of continual opioid therapy. So this was a little concerning to see this. And the next slide is going to be showing the responses by practitioners. So you'll see again, overall here, 20% of people overall got it correct. The people prescribing the opioids, only 34% got that right. And in fact, the highest scoring practitioner was a pharmacist, and that was still only 38% got that question correct. Now, in regards to the rest of the assessment, this wasn't probably the worst question overall. Out of 11 questions, people scored better than this. But I just looked over the results again. For the most part, the highest scoring answer, maybe 70% of the people got it right. So that still shows quite a bit of knowledge deficits from the very beginning of who is handling an opioid. And the bigger question I'll pose to everyone on the phone is this, and I ask this question all the time when I'm giving presentations on opioid safety. In a hospital, say all of you on this phone work in a hospital, how are you aware of the knowledge that your practitioners have in regards to the use of opioids? How do you know what your prescribers know and don't know? How do you know what the pharmacists and nurses know and don't know in regards to monitoring the patient, the appropriate dosing, et cetera, et cetera? And I'll tell you, often when I ask that question, I get dead silence, which means hospitals do not have a grip on not just opioids, probably a lot of drugs, anticoagulants, insulins. There's a basic a big missing opportunity here in regards to basic foundational knowledge of when it's appropriate to use an opioid. So the next assessments we did, now these are called organization assessments. This assessment is intended for a hospital to look at its processes within their hospital. 45 questions that were scored as either they fully did something, they did it partially or some of the time, or they did these practices not at all. And they addressed all phases of the medication use process from prescribing through monitoring and other questions like on PCA therapy. I'll also just skip over this slide for time. I think the most important thing, part of the gap analysis Michigan did, and when we did these assessments in Pennsylvania, is this step here, is getting a team together to look at this as a team in your hospital. This is not a pharmacy assessment, nor should it be done by a pharmacist, because we're asking questions about nursing, we're asking questions about prescribing, and pharmacists won't know that. So it's really important for people on the phone to understand that if we walk away when we use this tool, the best thing is getting the team together, because that's when you start getting dialogue of people saying, oh, I thought we did that all the time, but we don't do it at all, type of conversations. That does not happen unless you get a team together to look at these processes. So the next couple of slides, I'm not going to go over all the answers. Get an idea how people scored here. These are some of the lowest scoring items. So let's look at item 13 here. Pharmacists have easy access to the patient's opioid status, so they can look and know if a patient is naive or tolerant, and they take it in consideration. Well, here, almost 60% of organizations said they never do that. 24% they said they claimed they did it some of the time. Number 6, standardized pre-printed order forms or computerized prescriber order entry order sets are used to prescribe opioids. So basically saying, do hospitals have a standardized approach? So when people are prescribing an opioid, we're kind of all following the same rules by using this one order set. Again, 53% said none, 47% said they did it all the time. Last question, long-acting opioids are restricted for use only in opioid-tolerant patients, except for some lower dose MS-Contin. So you see the examples on this. They're only for opioid-tolerant patients. 53% of hospitals never restrict them. Other examples, and for time's sake, let me just pass along, I'll talk on the first one. Pain management protocols define opioid-naive and opioid-tolerant patients and outline the differences. So you see the scores here, but look to the right here. That 24% means that 24% of people answering this question did not even have pain management protocols in their hospital. And then add on top of that the other 53% who said they had their protocols, but they don't define opioid naive and opioid tolerant. So adding them together, 77% of the hospitals don't even touch the subject of opioid naive and opioid tolerance. Two other key items I'll share with you. Next slide here. We had a question about prescribers. So in your hospital, what does your doctor look for when they're writing an order for an opioid? And what type of things do they take in consideration that would affect the dosing? Maybe you want to lower the dose, how often you monitor the patient, and whether opioids are appropriate or not. And here are the 3 lowest scoring things, which I find shocking, especially when it's been known for years now that with patient-controlled analgesia, the one thing you monitor for is sleep apnea. Look how people scored here. So only 35% of people had their prescribers assessed for breathing difficulties like asthma, COPD, which will increase the chance for respiratory depression. Less than 30 did sleep apnea. Not even half considered that they're opioid naive or tolerant. Same question for PCA use below was scored even worse. And again, this has been a known fact for years and years to assess for breathing issues up here. And look how low they scored here. Last item deals with a question we asked for nursing. So in the nursing department, the questions were asked, what does a nurse assess a patient for before and after giving an oral opioid or an IV or parenteral opioid? So it's really 4 questions. I consolidated 2 here. The blue is how they answered. This is what the nurse assessed for before giving the opioid, injectable opioid. And the reddish color is what the nurses assess for after giving the opioid. So a couple key things here. Michigan talked about respiratory rate earlier, is how many people claim to assess for respiratory rate, but also quality respirations is just as important. How good is that respiration? Again, not even, maybe 70% got answered that said that they did that. Heart rate, other things that could be an indicator that things are going wrong with an opioid, level of sedation. Everyone did pain scale, you see over here to the right. But here's the concerning thing. You notice how blue is before, red's after. But you notice on respiratory rate, quality respirations, heart rate, blood pressure, pulse ox, etc., that all those red values went down, which is saying that those organizations admit they do fewer assessments after giving the opioid than before giving it. So just that whole process, and we're trying to bring to light here the process of monitoring a patient on an opioid in the hospital and what that process should include, but also when it should happen, and it's showing here that they claim to be doing fewer after the fact. And quickly, Michigan touched on their measures. You know, we measured two things in our organization. We specifically went after the use of naloxone to see if someone had a bad enough issue with an opioid that they had to be reversed with that. So I will say for everyone on the phone that this was not an easy measure, and people today, as of today, 2016, are really struggling to count this. And you may be asking, well, why are you counting this for? Why don't you just count the number of reports involving opioids? Well, in regards to error reporting, I can tell you that there are going to be way more instances of naloxone being given than you'll ever get in a paper report or electronic error report, adverse drug event report, whatever you want to term that. So this is a far more accurate number. I mean, it's not going to be perfect, but give people an idea of how much harm is going on. Similar to Michigan, we really saw a drop in naloxone use, especially after the organization assessment. In fact, you could see the downward trend going through the time period that they were assessing their organization for safe practices with opioids. The second measure we did, though, was something else. And so what we had people measure was rapid response team calls. So you're in the hospital and a code is called for you, and they'll call them code teams or rapid response teams. We had people assess, of all the times a rapid response team was called, how many of those times was it due primarily to an opioid? And I have to be honest with you, the real reason we proposed this measure was because from ISMP's perspective and from our experience visiting hospitals, we know that every hospital has a rapid response team, but rarely do they investigate why they're being called for. So you can picture a hospital with all these codes going on, people ran to the floor to take care of a code, but there's no process to identify, well, why was the code called? So that's why we're going to introduce this measure. And again, this measure actually went down over time really significantly as well, so I was very proud of that. So on that note, you'll see two links on the bottom there. The HAP Online is Pennsylvania's website in regards to all of their HEN projects, including the ADE. And the Patient Safety Authority's website is the location you're going to find under the Educational Tools section, an area for opioids. And within that area, you'll find the knowledge assessment we did, the organization assessment we did, a measuring tool that helps people kind of gather their measures for to start measuring like naloxone use over time, as well as the official write-ups. We actually wrote about the results of the organization once and a knowledge assessment twice. One last thing before I go. The knowledge assessment we repeated again a year and a half later, and I can tell you that 7 of the 11 questions showed statistically significant improvement. The bad news is that meant people, instead of getting 38% people got it right, maybe 45% of people got it right. So over a year and a half period, there was really, in my mind, not significant improvement in the basis knowledge of opioids in those hospitals. So on that note, I'll pass it back to the drivers here to see who's next.
We now turn the webinar over to our final presenter, Dr. Anita Gupta. Dr. Gupta is a board-certified anesthesiologist, pain specialist, and pharmacist. Currently, she serves as vice chair and associate professor at Drexel University College of Medicine in their Department of Anesthesiology, a CEPOP participant, Dr. Gupta is also an advisor to the Food and Drug Administration on the Anesthetic and Analgesic Drug Products Advisory Committee and will provide a clinical perspective on today's discussion. Welcome, Dr. Gupta.
Thank you very much. It's a pleasure to be here, and I'm very happy to discuss what we're doing and my thoughts on how to mitigate this issue. So we'll begin by talking about what I'll be speaking about today, as briefly we'll be talking a little bit about the opioid epidemic, some of the opioid-sparing techniques that I utilize, and what multimodal treatment really is all about. Something that I believe hospitals can do, and then we'll also review some of the best practices that we heard about earlier today, and my thoughts on why they work. And also a really important topic that is so critical to day-to-day work in the hospital is how to facilitate the change, and how do you make your community accept some of the changes in what we do already. And then I'll summarize by just going over some key things that you can take home with you to your communities and hospitals. So as you all know, the burden of the opioid epidemic is enormous. Approximately 23 million people have surgery each year in the United States. And despite that, despite all the things that we're doing, 40 to 50% of patients after surgery still report inadequate relief. And that's something I see day to day in the hospital when patients are coming out of surgery. We do multiple things, but even then patients are not well controlled. And even with all of this, the cost of care is increasing, and there's very, very little improvement on the health status of these individuals. As you all know, there's 100 million people in the United States that have chronic pain now, and in addition, 78 patients die every day from opioid overdoses. So even with all the efforts that we're putting forward, we're still on the front lines of trying to solve this epidemic. So one of the biggest issues I see in the hospital, and that is a constant balance that we need to strike, is finding pain relief for a patient, at the same time mitigating the risk of abuse, and also ensuring that we can afford multimodal care. Patients who use opioids generally are perceived as being very difficult to manage. They're costly and complicated. And many clinicians and management of different hospitals will turn a blind eye to these patients. But in my own institution, I have been perceived as a champion to advocate for pain relief and to use multidisciplinary groups in a challenging environment. Even when the emphasis is on quality of care, even when we're trying to lower reimbursements and insurance coverage, we can still offer our patients quite a bit. So what is multimodal? Well, to understand multimodal, you need to understand what, for example, postoperative pain is. And if you look at people who have surgery, as many of you or maybe your loved ones have had, pain is not just one symptom. It is an encompassment of so many different other symptoms. There are problems at the level of the skin, all the way down to the nerves, to the actual organ itself. It could be a reflex response. It could be something that's coming from the brain. But in fact, the way we understand pain now is that it is not just one symptom. It is actually a combination of different things that an individual is having, particularly after surgery, which is the best example of pain. To understand really why pain occurs, you need to understand that there are many sources of pain. And when a patient says they have a 10 out of 10, it's up to the pain specialist or the doctor taking care of them to identify which one of these is really contributing to their pain diagnosis. But one of the things that I do in our hospital at Drexel University is that we encourage multimodal or opioid-sparing analgesia. And this is often done on a routine basis. It's not really thought of something, an option. We offer patients opioids. We know opioids are the cornerstone of treatment, and we will continue to offer that. But in addition to that, one of the things that I champion is that we need to encourage using physical and occupational therapy, procedural treatments such as nerve blocks, and using simultaneously 2 or more analgesic drugs together so that you can address different mechanisms of pain and also different mechanisms in the way these drugs work. And sometimes multimodal, or otherwise known as combination therapy, may actually have a synergistic effect and may actually allow for lowering the dose of the opioid therapy. One of the basic WHO principles is, to treat a patient by the clock when they have pain, meaning giving them around-the-clock medication by the age of the patient, making sure that you're addressing for anyone that's an elderly patient or a child, making sure you're dosing the medications appropriately to prevent that overdose, and using the appropriate route, because that can also affect how beneficial the treatments are. In addition, patients who have open mind to integrative therapies will include massage, heat and cold, deep breathing, biofeedback, and hypnosis in conjunction with the pharmacological options. So multimodal isn't all about pharmacologics. There are other things, as you heard about today: patient education, psychological therapies, interventional therapies, procedures, and physical therapies. But as we all know, that pharmacologics tend to be the most commonly used medication for the treatment of pain, and that's why we're here today to try to find other alternatives. But in order to understand that, you need to understand the whole pie, and that there are other things that can be done to help mitigate the opioid epidemic without opioids or in conjunction with them. And really, the goals of multimodal are really, one, to improve the analgesic quality by giving them synergistic options, achieving more of a balanced pain control, and reducing some of the adverse events. We need to consider any time that an individual is given an opioid that we need to take proactive steps before the opioid is prescribed, and this is something that I'm in constant discussion with my hospital and community members to make sure the patient understands all the risks, the benefits, understands how to discontinue treatment, and also considering, all the real risks that could include an opioid overdose. One of the common things that I discuss with my trainees and my colleagues is that opioid overdoses can occur to anyone, anytime, anywhere, whether you're an opioid user or not. Family members, loved ones, and the environment of anyone that's using an opioid are also at risk. So it's important that as a clinician taking care of these patients that we educate them not only on the opioids and the risks, but also the benefits, the other options, and also caution them before we even prescribe. So what can hospitals do and why? I mean, we've heard a lot today from Michigan and Pennsylvania, the amazing work that they're doing, and also from Kate Goodrich about the work that's being done on a national level. But really, questions that I get in my own hospital when I first approached them was that, why do we need to do this? Why is it so important? Well, there's so many reasons that we need to do this. The prevalence of chronic pain is growing. 100 million adults in the United States have it, which is outnumbering cancer, diabetes, and heart disease combined. And the number of surgeries are going up. People are having more surgery more than ever. And in order to ensure that they have good pain control, it's important that we have, in conjunction with surgery, good pain services. And with all of that, we have to keep in mind that we have a major public health crisis. By decreasing the amount of opioids, we can decrease the amount of opioid-related complications. We can decrease length of stay. We can, in my experience, improve patient satisfaction. My patients, when they're on less opioids, they tend to be able to communicate with their family members and loved ones so much better, so they're much happier. But there's still a lot of work ahead, and we definitely can do more. And these are some of the things that I've done in my own hospital. What hospitals can do, and what a champion at your own communities can do, is really organize committees to address the epidemic, include patients, include doctors, pharmacists, anyone that wants to be there. We even have IT individual there to tell us about some of the technological things that we can do, and we make sure that each person has a clear idea of what they're supposed to do. In addition, benchmarking the data, collect data on outcomes. As we've heard from Michigan and Pennsylvania, standardize what you're doing in your hospitals, use protocols that are clear and concise so that everyone has a certain expectation, and ensure that those models are multimodal, that they are multidisciplinary, that they emphasize not only the physical pain that people incur, but also the psychological and biological aspects of that and social aspects of it. Frequent assessment. One of the campaigns we ran at our hospital is called the Comfort Campaign, and all the campaign was about was telling the patient when we walked in the room that we're going to do everything we can to make them feel better. And that simple fact really made a difference in patients' lives and their hospital stay. They just knew that someone was there assessing them, that someone was there that cared about their pain, and they felt engaged, and they felt like they could ask questions without any stigma regarding their pain. We ensured that we increased safeguards. We talked about how to use naloxone safely, not just having it, but how to use it. Ensuring that physicians knew how to use their prescription monitoring programs within their state. And we also created a platform to connect services, meaning if someone came in with a history of pain or heroin addiction or some other crisis, we were able to connect those point or key people in those services so we could connect our patients to them quickly. Now, we heard about a lot of best practices in Michigan and Pennsylvania, but I want to highlight them in my thoughts and some of the things that we believe are important to note about them. For example, in Michigan, the CUSP initiative is so important. I mean, it's comprehensive. It's specific to the population that you apply it to. It promotes changing of culture, and it obviously improves patient safety. Having coaching calls or webinars, as Michigan is doing frequently, demonstrates to the clinicians that there is an investment in education and that there's an investment in raising the bar in education. One thing is, raising the bar is so critically important on this epidemic. Clinicians, as we heard in Pennsylvania, don't always have the understanding of what an opioid does and what the risks are and when you can become tolerant. So having that discussion can certainly raise the bar in the education for the hospital and the community. Having the tools that we heard about in Michigan, the gap analysis, the preoperative checklist, the MOS tools, really establishes consensus, and this is so important. Establishing consensus within your community, with having best practices, having tangible tools in place that can be used quickly and effectively really provides a clear action plan. It also allows for clear documentation, particularly in patients who are taking opioids. Now, if we turn our attention to Pennsylvania, there's also some excellent tools that have been put in place. The opioid knowledge self-assessment, there's some great information that was gathered from that. We were able to identify gaps in knowledge, we're able to raise the level of expectations, and it really serves as an eye-opening self-assessment tool, not only for the person taking the checklist or their own self-assessment, for the outsiders looking in to see what the deficits are within their system, to make sure that those are addressed quickly and clearly. Organizational assessments that Pennsylvania is doing helps benchmark data. And by doing that, you can actually develop protocols that are based upon a certain population. They'll help improve the process within that community. And lastly, one of the great things that they're doing is advocating for naloxone and having that RRT, or the rapid response team, involved in understanding that opioid overdoses can occur even in the hospital. This establishes the breadth and scope of the educational need, and it also, again, provides that collaborative action plan that everyone should know about. So one of the most important things that take from my discussion today is really understanding how to facilitate all of this, how to anticipate the challenges, and how to make these things really happen within your own hospital setting or community. And I can tell you from my own experience, my own hospital was very conservative. They were not advocates for creating a pain service, nor were they, really on board with making change, and that was 5 years ago. It took a long time to get everyone on board, and how I specifically did that was becoming that voice for my patients, becoming that champion for my colleagues. I joined my Pharmacy and Therapeutics Committee as a member to advocate for some new medications that may help mitigate or minimize the amount of opioids. I created an advocacy campaign, as I mentioned earlier, that was called the Comfort Campaign, which circled around good communication. And I lead a service of many, many different multidisciplinary specialties. And I think in order to implement a lot of these changes, there needs to be a certain individual or person within your community that can lead these endeavors. Without that, there's really no structure or accountability, and it can cause these great ideas to never come to fruition. It's important to keep in mind that to implement some of these changes, it's important to engage staff. And how I did that is by having in-services, talking to them both as a pharmacist and as a physician about how these changes can really help patients, help them enjoy what they do today, and reduce the likelihood of complications.
And to all of our presenters, a big thank you on today's webinar. We'd like to open it up now to question and answer. Looks like a couple have been submitted already, and if you have any additional questions, just go to the bottom right corner with Q&A. You can ask a question and hit the return button. So we had a question earlier. I think this was on Michelle's presentation. We had a question about, was asked, can you tell me more about the social media campaign?
Yeah, I'd be more than happy to. So our social media campaign was on the 10 things every patient in pain should know, and it was twofold. First was that every single day we provided an item for patients to become aware of, and it was launched on Facebook, Twitter, and LinkedIn. In addition to, a brief snapshot of what they should know, we provided them with additional resources that they could also utilize. And if you go to our Twitter account, which is Michigan Health and Hospital Association, we'd be more than happy to share that information of what we pushed out. The second piece of that was a Twitter chat, and we engaged partners across the state of Michigan, including the Michigan State Police, the Michigan State Medical Society, Michigan Osteopathic Association, Michigan College of Emergency Physicians, and we also engaged practitioners in the work, as well as the Engaged Patients and Empowered Patient Coalition, which we developed the tool with. And it was a scheduled 1-hour chat, which we had questions that went out about every 10 minutes or so, and then a chat went back and forth providing answers and responses from each of the different areas of specialties. And within that 1 hour, we made the 1.5 million impressions, which we were really excited about. I think that, again, opioids is such a hot topic, but I also think that a lot of patients and family members are really interested in knowing more and knowing what they can do to protect themselves and their families.
There was a question asked, is there a preference for capnography versus pulse ox monitoring for PCA or other patients receiving opioids on an inpatient basis? Anyone want to take the first stab at that?
Yeah, I'd be happy to. That's actually one of our recommendations from the MHA Keystone Pain Management. And one of the things that we have heard over and over from our hospitals is that capnography is very cost prohibitive in a lot of our organizations. So the interesting thing about Michigan is that we have very few large cities. There's one really large city, and then the rest of it's fairly rural. And so a lot of our hospitals do not have the financial components in order to have capnography for all patients or all patients that are even on PCAs. That being said, we've done a lot to really educate that if you are not using capnography and you're only using pulse oximetry, that you need to make sure that you're not providing supplemental O2 to those patients. So there have been several instances in which a patient's on supplemental oxygen, they're on a PCA, and they only have pulse ox, and it artificially inflates your pulse ox rate to the point that you're not able to be rescued in time. And so that has been something we are very aware of in a few of our hospitals that have had patients that have succumbed due to that specifically. And so we are just making sure that hospitals are aware that if you are putting patients on supplemental O2 that you should utilize capnography, and otherwise you certainly can use pulse oximetry.
Okay, great. Any other? Anybody else want to weigh in on that one?
Just real quick. So I think people need to understand with pulse ox, yeah, it may be okay, but often if you're waiting for that alarm to go off on the pulse ox if someone's being oversedated with an opioid, they're already on their way downhill. So it's not like admitting the alarm goes off, oh, we still have plenty of time to rescue this patient. Often they're already starting to have lesser quality respirations, a lower respiratory rate per se, but the saturation may be okay. So I think people just need to understand that's possible. I mean, I definitely understand there's a cost with capnography, but I'm concerned about sometimes the reliance only on pulse ox when you may be getting a signal that something is wrong too late. That's all.
Okay, thanks. Appreciate that. Another question has come in for whoever wants to take it. Please expand upon reliable and objective methods for assessing individual and patient-specific risk for opioid misuse or abuse. I want to address that one. takers? Well, I think that's a question we'll have to get back to afterwards. Any other questions?
I have a question, Rich, if you don't mind. And this goes for all of our presenters today. But with some of the heightened awareness surrounding the opioid epidemic throughout the country nowadays, how has government actions and current legislation helped to improve some of the progress made towards combating the epidemic itself?
This is Matt. I honestly think that the HEN projects in themselves was a good starting point in that there's dedicated funding to address that broad topic of opioid, I'm not if I would say misuse, but as you said earlier, a lot of these problems of the opioid epidemic starts when it's originally prescribed by a practitioner. So I think with the HEN projects helped us to get groups of hospitals together to share information on what works, what doesn't work. It helped push the relevance of measuring for the safety of opioids with naloxone. So I think from that perspective, the CMS and the HEM projects were definitely well worth the time.
And I would totally agree with Matthew. I think that, the monies that have been put forth in order to target this epidemic, I think, has been a wonderful addition. There's a lot more resources, even including providing naloxone to first responders that has happened. In Michigan, Governor Snyder put together a task force to put out recommendations on items they wish Michigan to focus on, specific to prescription drug and opioid abuse. And so, as hospitals, we're one of the first lines of defense to prevent addiction. And I think that, we're all working really hard on making an impact related to this, that we are providing opioids safely, that, as Dr. Gupa indicated, that we're following the WHO pain ladder as an example. And we're working to make sure that not only are we trying to prevent addiction, but we're also working on implementing items recommended by the task force, including public awareness campaigns, increasing medication disposal options, educating providers on neonatal abstinence syndrome, which is a really hot topic right now, and even pushing out recommendations through our Michigan College of Emergency Physicians. So we're really trying to partner with a lot of institutions and organizations across the state so that collectively we can make a larger impact. And I think that that's why partnerships and learning opportunities such as this are so important to all of us.
So I'd have to agree with both of those comments as well. I definitely think that some of the policy that we're seeing come forward has really made already quite a difference in the education, the understanding. I can recall just 10 years ago, my patients did not know what an opioid was. Now they do, and they ask me questions about it before it's even prescribed. So there's definitely a lot of education that's occurring. Patients are more aware. There's more instruction on how to use these medications safely and responsibly, and what the role of multimodal therapy is, and how to use things other than non-opioids. I think that there's some of the progress that I'm seeing on the clinical side. In addition, all of the new policies that are being put forward through the federal government, from the FDA to the CDC, and also Congress with CARA. So there's definitely great progress that's being put forward, and I'm happy to see more.
And Matt, just to answer that question that came in related to individual patient-specific risk for misuse or abuse, I just want to clarify that from the MHA Keystone standpoint, we're not necessarily focusing on those receiving medications and misusing or abusing them. We're really trying to work to reduce opioid-related adverse events, to improve patient management, and to decrease the usage of opioids statewide, and then increasing expectation management for patients. So we're not necessarily targeting who is going to misuse or abuse medications, but rather safe utilization of opioids and pain medications.
Thanks a lot. We have a few minutes left here, but I wanted to see if any of our presenters had any questions of their own and or a final comment that they'd like to make, if anyone wants to weigh in before we close it out. Hearing none. I'm sorry, go ahead.
This is Michelle, and I was just going to say I've really enjoyed the talk today, and I think if anything, you know, it's really great to hear a lot of the commonalities between even Pennsylvania's HEN and our own in terms of items that we're pushing out. And I think that there's a lot of great evidence-based best practice out there. Opioid naive and tolerant is something we're also focusing on, and equal analgesic dosing. And I think that there's a lot of low-hanging fruit out there that we certainly can target to continue to make improvements.
Great, thanks. Anyone else? Well, thanks for all the questions and for participating in today's webinar. We hope that our discussion served as an opportunity to share best practices and provide participants with an opportunity to understand the ongoing efforts by hospital engagement networks throughout the country to help combat the opioid abuse epidemic. Certainly a lot of great discussion today, and I think we all learned a lot. Should you want more information on CEPOP, including possibility of joining the collaborative, please visit www.cepoponline.org. As we conclude today's webinar, we'll ask that you respond to a short 5-question survey that'll pop up on your screen. Your feedback is greatly appreciated and will help shape these programs moving forward. If you have not yet done so, also welcome additional nominations for the CEPOP Salutes Awards Initiative. Again, thank you all for joining us today. We'll give you 10 minutes back on your busy schedules today, and a reminder that a full recording of the webinar will be posted on the CEPOP website later this week. Have a great day, everyone.